Welcome back to the deep dive. Today, we're really focusing in on red blood cell disorders. We want to master those core concepts.
That's right. We're taking the essentials from Porth's Pathophysiology, Chapter 23, and trying to build a really clear map for you.
The goal isn't just reciting facts, is it? It's about understanding the why.
Exactly. The clinical reasoning. Why do these symptoms happen? If you grasp the underlying mechanisms, you're well on your way to mastering the subject. And it all starts with the red blood cell itself, the erythrocyte. It's quite an incredible little machine.
Okay, so let's unpack that. The numbers alone are staggering, right?
Yeah.
500 to 1,000 times more numerous than other blood cells.
Yeah, just vast quantities. But the shape, that biconcave disc shape, that's really ingenious. And it doesn't have a nucleus.
Why that specific shape?
Well, two main reasons. First, it maximizes the surface area relative to the volume. That's key for fast oxygen diffusion, getting oxygen in and out quickly.
Okay, faster diffusion. What's the second reason?
Flexibility. The membrane itself is incredibly pliable. It has this internal scaffolding. A protein network spectrin and anchorin are the key ones.
And that flexibility lets it do what exactly?
It allows the cell to literally deform, to bend and squeeze through the absolute tiniest capillaries in your body, capillaries much narrower than the cell itself. That's how it reaches every tissue.
Wow. Without that, it just wouldn't work.
It would break apart. Yeah. Fragile cells get destroyed prematurely, and inside that flexible container is the main event, hemoglobin, HB.
The oxygen carrier carries almost all of it, didn't you say? Like 95 to 98%.
Pretty much all of it. It's the primary vehicle.
Yeah.
And structurally, it's 4 polypeptide chains, each linked to a heme unit containing iron. So one hemoglobin molecule grabs 4 oxygen molecules.
And there are different types, right? Adult versus fetal hemoglobin.
Yes, HbA versus HbF. And this is fascinating. HbF, fetal hemoglobin, actually has a higher affinity for oxygen. It holds on to it more tightly.
Why would that be?
Think about the placenta. The fetus needs to effectively pull oxygen away from the mother's hemoglobin. That higher affinity makes the transfer possible.
Ah, clever. And then that changes after birth.
It does. Over the first 6 months or so, HbF is gradually replaced by the adult form, HbA.
Okay, so making hemoglobin needs iron. You mentioned iron earlier. How does that whole iron cycle work?
Right. Iron availability is crucial for the synthesis rate. Now, you do get some dietary iron, especially from meat, absorbed in the duodenum, but the body is incredibly efficient at recycling.
Recycling from where?
From old red blood cells that get broken down. Most of the iron we use is actually reclaimed. It gets transported by a protein called transferrin and then stored mainly as ferritin.
So if I want to check someone's iron stores...
You measure their serum ferritin level. That's your best indicator of how much iron is actually stockpiled in the body.
Got it. Now, the production itself, erythropoiesis, happens in the bone marrow, but what actually triggers it? What's the signal?
It's all about tissue oxygen needs. If your tissues aren't getting enough oxygen, that's hypoxia, specialized cells in the kidney, the peritubular cells sense this.
So it's the kidney, not the bone marrow, that notices the low oxygen.
Exactly. The kidney responds by producing a hormone called erythropoietin, often called EPO.
And EPO does what?
It travels through the blood to the red bone marrow and tells the precursor cells there to wake up, divide, and mature into red blood cells faster.
Ah, so that's the link. If someone has kidney failure.
They can't produce enough erythropoietin, so even if they're hypoxic, their bone marrow doesn't get the signal to ramp up RBC production. That's why anemia is so common in chronic kidney disease.
Okay, that makes sense. And we can measure how active the marrow is by looking for reticulocytes.
Precisely. Reticulocytes are the immature red blood cells just released into circulation. Normally, they make up about 1% of the RBC count.
But if production ramps up...
Then that percentage shoots up. After major blood loss, for instance, you might see the reticulocyte count jump to 10, 20, even 30%. It shows the marrow is working overtime.
So they live about 120 days, these cells. What happens at the end of that lifespan?
They start to wear out. Their metabolism slows down. The membrane gets more fragile. They eventually get trapped and destroyed, mainly in the spleen, by phagocytic cells.
And the breakdown products, what happens to the hemoglobin?
The iron gets recycled, like we said. The globin chains are broken down. But the heme part, that's converted into bilirubin. Initially, it's unconjugated bilirubin.
Unconjugated meaning?
Meaning it's not water-soluble yet. It has to travel, bound to albumin, to the liver. The liver then conjugates it, makes it water-soluble so it can be excreted in the bile.
And if too many cells break down too quickly?
The liver gets overwhelmed. It can't conjugate all that bilirubin fast enough. So unconjugated bilirubin builds up in the blood, and because it's pigmented, it deposits in tissues, causing jaundice, that yellow discoloration of the skin and eyes.
Okay. And what if the destruction happens inside the blood vessels?
That's a bit different. Intravascular hemolysis releases hemoglobin directly into the plasma. That's hemoglobinemia. If there's too much, it spills over into the urine, causing hemoglobinuria.
Right. So lifespan, destruction, bilirubin. It's quite a cycle. Let's switch gears to when we add cells transfusions. When are they typically needed?
Generally, it's about compromised oxygen delivery. A common trigger point is a hemoglobin level less than 7 grams per deciliter, though it really depends on the whole clinical picture, the patient's symptoms, and stability.
And the big risk is incompatibility, right? ABO and RH systems.
Absolutely. The ABO system is based on having A or B antigens on the red cell surface. Crucially, you naturally develop antibodies in your plasma against the ABO antigens you lack. Type A blood has anti-B antibodies, type B has anti-A, type O has both, type AB has neither.
But RH is different with a D antigen.
Yeah, the Rh system works differently regarding antibodies. Unlike ABO antibodies, which develop spontaneously, Rh antibodies, specifically anti-D, only develop after an Rh-negative person is exposed to Rh-positive blood.
Exposure like a previous transfusion
Or pregnancy, if an Rh-negative mother carries an Rh-positive baby. That sensitization is key.
Okay, so let's say a mistake happens. What's the most dangerous immediate reaction?
That would be the acute hemolytic transfusion reaction, AHTF. It's rare now, thankfully, but life-threatening. It's usually due to ABO incompatibility. The recipient's antibodies just attack and destroy the donor red cells right in the bloodstream.
And the major danger there isn't just the cell loss.
No, the big immediate danger is often kidney failure. The massive release of hemoglobin from the destroyed cells gets filtered by the kidneys, and it can clog up the renal tubules, leading to oliguria or even complete shutdown. You have to watch urine output like a hawk.
Scary.
Yeah.
What about other, maybe more common reactions?
The most common is a febrile non-hemolytic reaction. This is usually the recipient's antibodies reacting against donor white blood cells, leukocytes. Causes fever, chills. It's uncomfortable, but not usually dangerous.
Treatable with antipyretics. Preventable.
Yes, antipyretics help. And using leukocyte-reduced blood products largely prevents it.
Then there are the really serious lung-related ones, TRALI and TACO.
Right, TRALA transfusion-related acute lung injury. This one is serious, potentially fatal. It seems to be an immune reaction targeting the lungs, causing sudden pulmonary edema, low oxygen, low blood pressure, usually within 6 hours of the transfusion.
And TACO, that sounds different.
It is. TACO transfusion-associated circulatory overload. This isn't an immune attack. It's basically fluid overload. You've given too much volume too quickly, especially in someone with underlying heart or kidney problems, maybe an elderly patient. Their system can't handle it. Fluid backs up into the lungs, causing respiratory distress.
So TRALI is immune-mediated lung injury. TACO is volume overload. Very different mechanisms.
Very different, but both cause acute respiratory distress. Critical to differentiate.
Okay, let's move from adding blood to lacking blood anemia. What's the basic definition?
Simply put, anemia means you have a low number of circulating red blood cells or a low level of hemoglobin, or both. The end result is impaired oxygen transport to the tissues.
And how does that manifest? What's the typical clinical picture?
It flows directly from that lack of oxygen. Fatigue, weakness, shortness of breath, dyspnea, maybe headache or feeling faint, dim vision. The body tries to compensate too.
How does it compensate?
It increases heart rate and cardiac output to try and circulate the remaining blood faster. That can lead to tachycardia, palpitations. In severe cases, you might even hear heart murmurs or see signs of heart failure.
And the classic pallor, the paleness.
That's due to less hemoglobin in the vessels near the skin and also the body shunting blood away from the periphery towards vital organs. Though, remember, if the anemia is caused by hemolysis, you might see jaundice instead of pallor.
And sometimes other signs, like bruising and aplastic anemia.
Exactly, because aplastic anemia affects platelets too. So the signs depend on the cause of the anemia.
Which brings us to classification. Labs are key here, right? Especially RBC indices like MCV and MCHC.
Absolutely. MCD tells you the average size of the red cells. Are they small, microcytic, normal, normocytic, or large, macrocytic? MCHC tells you about the hemoglobin concentration inside the cells. Are they pale, hypochromic, or normal color, normochromic?
And these help narrow down the cause.
Immensely. For instance, let's take blood loss anemia.
Yeah.
If it's acute, massive blood loss, the cells initially look normocytic, normochromic, because you've lost whole blood. The immediate problem is volume shock.
But chronic blood loss.
That's different.
Right.
Slow, steady loss, like from a bleeding ulcer or heavy periods, gradually depletes the body's iron stores. Without enough iron, you can't make hemoglobin properly, so the cells become small and pale, microcytic hypochromic. That's iron deficiency anemia, IDA,
Which you said is the most common type worldwide.
by far. Usually due to chronic bleeding or sometimes poor intake or absorption. And besides fatigue, you look for those specific clues.
Like Kaipaya, craving ice or dirt.
Exactly. Pica, koilonychia, those brittle, spoon-shaped nails, and a smooth, sore tongue. Those strongly suggest IDA and prompt you to find the source of that chronic loss.
Okay, moving to the large cell anemias, the megaloblastic ones. What's the underlying problem there?
The core issue is impaired DNA synthesis. This messes up cell division and maturation of the bone marrow, leading to these abnormally large, immature red cells, macrocytic cells. The two main culprits are deficiencies in vitamin B12 or folic acid.
And is there a way to tell them apart clinically?
Yes, and it's absolutely crucial. Vitamin B12 deficiency, often caused by pernicious anemia where the stomach fails to make intrinsic factor needed for B12 absorption.
That one has neurological consequences.
Yes, this is the key differentiator. B12 is vital for maintaining the myelin sheath around nerves. Without it, you get abnormal fatty acids incorporated into neuronal lipids, causing damage. This leads to characteristic neurological symptoms, symmetrical numbness and tingling in hands and feet, paresthesias, loss of balance and coordination, ataxia, confusion.
But folic acid deficiency doesn't cause those nerve problems.
Correct. Folic acid deficiency causes the exact same large red cells, the macrocytic anemia, but without the neurological manifestations. It's more often linked to poor diet, alcoholism, or increased needs like in pregnancy. The treatment and urgency are different because of the lack of irreversible nerve damage compared to B12 deficiency.
Got it. B12 equals neurosymptoms possible. Folate equals no neurosymptoms. What about aplastic anemia?
Aplastic anemia is a really serious one. It's a disorder of the bone marrow stem cells themselves, the pluripotential cells that create all blood cell lines. So you get pancytopenia.
Pancytopenia meaning low levels of everything.
Everything. Red cells, white cells, and platelets. So the symptoms reflect that. Fatigue and weakness from anemia, increased risk of infections from low white cells, and bleeding or bruising easily from low platelets. The cells themselves are usually normal size and color, normocytic, normochromic, there just aren't enough of them.
And quickly, anemia of chronic disease. We touched on the kidney link.
Yeah, that's a major cause, especially chronic kidney failure leading to low erythropoietin. But other chronic inflammatory conditions can also cause it, often through inflammatory cytokines interfering with iron utilization or EPO response. It's typically normocytic anemia.
Okay, so we've covered deficiencies. What about the opposite? Too many red blood cells. Polycythemia.
Right, an abnormally high total red blood cell mass. We usually look at the hematocrit, the percentage of blood volume occupied by red cells. Over 54% in men or 47% in women is generally considered polycythemia.
And too many isn't necessarily better.
Definitely not. When the hematocrit gets really high, say over 60%, the blood becomes incredibly viscous, really thick. This actually impairs blood flow and oxygen delivery, paradoxically causing hypoxia, and it massively increases the risk of blood clots, thromboembolism.
How do we categorize it? Primary versus secondary?
Yes. Primary polycythemia, or polycythemia vera, is a neoplastic disorder. It's like a cancer of the bone marrow, where it just starts overproducing red blood cells, often along with white cells and platelets, without any normal stimulus.
So the marrow is just running wild.
Pretty much. This leads to increased blood volume and that dangerous hyperviscosity. Patients often feel headachy, dizzy, might look flushed, or have a dusky, ruddy complexion. Plethoric is the term. The main treatment is aimed at reducing that viscosity, usually by regularly removing blood therapeutic phlebotomy.
And secondary polycythemia.
That's not a marrow disease itself. It's a response to something else, usually chronic hypoxia. The body is trying to compensate for low oxygen.
Like living at high altitude.
Exactly. Or having chronic lung disease, or even heavy smoking. Anything that causes long-term low oxygen levels makes the kidney pump out more erythropoietin, which tells the bone marrow to make more red cells. Here, the treatment isn't phlebotomy, it's addressing the underlying cause of the hypoxia if possible.
Makes sense. Compensatory versus neoplastic. Now let's bring it to the lifespan extremes. How do things look in a newborn?
Newborns have unique physiology. They start with very high hemoglobin levels, largely HbF, remember. This concentration then drops quite rapidly over the first couple of months,
Leading to that physiologic anemia.
Yes, the physiologic anemia of the newborn, around 2 months old, as HbF switches to HbA in production, finds its new baseline. But the bigger immediate concern is often hyperbilirubinemia jaundice.
Why are newborns so prone to jaundice?
Two main reasons. They're breaking down those excess red cells they were born with, releasing lots of bilirubin, and their liver's conjugation system is still immature, so it can't process the bilirubin efficiently yet.
And the danger level depends on the type of bilirubin.
Absolutely critical point. It's the unconjugated lipid-soluble bilirubin that's dangerous. In newborns, the blood-brain barrier is more permeable. High levels of unconjugated bilirubin can cross it and deposit in the brain tissue, causing a devastating condition called kernicterus.
Leading to brain damage.
Severe brain damage, rigidity, seizures, potentially death. That's why we monitor bilirubin levels so closely.
How is it treated?
Mild jaundice might resolve on its own. More significant levels are treated with phototherapy special lights that convert the unconjugated bilirubin in the skin into a water-soluble form the baby can excrete. In very severe cases, or in things like hemolytic disease of the newborn.
Where the mother's antibodies attack the baby's cells?
Right, usually due to Rh incompatibility. In those severe cases, an exchange transfusion might be needed to rapidly remove the bilirubin and the antibodies. Prevention with Rh immune globulin, ROJAM for Rh-negative mothers, is key for that specific condition.
Okay, finally, the other end of the spectrum. Aging. Does our red cell production change as we get older?
It does seem to diminish somewhat. Anemia becomes much more common in older adults, especially after age 85. While their baseline levels might be okay, their ability to ramp up production in response to stress, like bleeding, is often blunted.
So the reserve capacity decreases.
Exactly. They can't replace lost red cells as quickly. This seems partly related to age-related inflammation, which can make the bone marrow less sensitive to erythropoietin, and they just don't respond as robustly. So if we pull it all together, we've really looked at red cells from cradle to grave almost. We've covered the structure, the production signals like EPO from the kidney, the destruction in bilirubin, the deficiencies causing anemias, the excesses in polycythemia, and the age variations.
It really highlights how interconnected everything is. Kidney, liver, spleen, bone marrow, nutrition, all focused on this one tiny cell's job.
Absolutely. And understanding those connections is key.
So we've walked through quite a bit, from the basics of the RBC to complex disorders. We hope this deep dive helps you connect those dots.
We talked a lot about that biconcave shape and the flexibility from spectrin and ankyrin. So what does this all mean? Think about what happens if that protein framework is faulty from birth, maybe a genetic defect. The cell becomes rigid, maybe spherical instead of concave.
It wouldn't be able to squeeze through those capillaries.
Especially not through the spleen's filtration system. The spleen is designed to remove old, stiff cells. If these congenitally rigid cells hit the spleen, they can't deform, they get trapped and destroyed prematurely.
Eating too.
Chronic hemolytic anemia, like hereditary spherocytosis. The fundamental problem is that loss of flexibility due to the defective internal structure. So understanding the structure helps you understand a whole category of disease.
A fantastic point. The structure dictates the function, and defects in structure lead directly to disease. A perfect encapsulation of pathophysiology. Thanks for joining us on this deep dive into red blood cells.